much, Dr. Harris. It's an honor to be here and to be a part of this panel. Thank you for that question. I think what I'll start with is to just make the point that where this all started. First, we know that there are a multitude of health outcomes that differ in prevalence and severity by race or ethnicity or along other socio-demographic lines. And so we know that there are differences in these outcomes when it comes to different types of cancer, whether it's colorectal cancer, lung cancer, breast, ovarian cancer, whether we're talking about heart disease or infant maternal mortality, or even surgical outcomes, so vaginal birth after C-section, or and the likelihood of success in some of those sort of clinical scenarios. And so that's not debated. I think the real question is when we step back and we observe these differences in health outcomes by race specifically, the question is why? And what Dr. Brody shared and what you just shared, Dr. Harris, what we know is that this is a complex, historical, multifaceted problem that spans multiple social ecological levels. So it's a complex problem as to what has caused and led to these and promoted these health disparities that we have seen for a long time and continue to see today. Racial bias in healthcare, I think, is certainly an important contributor to this disparity, although right now we don't exactly know to what extent. When we talk about racial biases, in general, there are two ways that we think about it, and especially how they present in healthcare. So biases can be explicit or implicit or subconscious. So explicit biases, and I'm not going to spend too much time talking about this today, but these are the types of biases that directly or intentionally take into account observations made based on an individual's race. And so in recent weeks, there's been a lot of discussion around whether we should really be using race in some of these risk calculators or clinical algorithms. And the reason for it being called into question is if we don't know why the disparity exists, and then we go ahead and we do logistic regression and we put race as a predictive variable in a clinical algorithm, then we run the risk of perpetuating those disparities because it's not a genetic difference. It's not, race is a social construct. It's not a biological, there's no biological basis for race in this country. So that's explicit bias. The other type of bias, which I'd like to press a little bit more into, is implicit or subconscious bias. And so these are the attitudes or stereotypes about an individual or a group of people that occur on this unconscious, involuntary level. And the two important things to remember about implicit bias is that, one, we all have it. It's not a matter of do you have it or do you not have it. We all have it. And so it's not this, and the second point about it is it's not this intentional belief or idea. And so the goal isn't, when we talk about implicit bias, the goal is not to demonize anyone or isolate anybody, but nonetheless, we have to commit to acknowledging them and addressing them if we are committing to the longitudinal work of anti-racism, specifically as it pertains to this discussion. And so with implicit bias, there have been studies that have shown that it can influence clinical decision-making. It can bias people, again, on that subconscious or involuntary level to make snap judgments that lead to decisions that might disproportionately or differentially impact certain groups of people, specifically Black Americans. And so the thing about implicit bias studies is that implicit bias itself is a difficult construct to study. And for good reason, right? It's difficult to measure because it's actually something that if we do anything voluntary with implicit bias, we voluntarily suppress it. And so then the way that we can measure it, at least in a study design, is it tends to be through the main mechanism tends to be through the implicit association test, or the IAT. And so that is just one way of measuring implicit bias. It's not going to capture the entire spectrum of it. And so despite the studies showing some conflicting associations between implicit bias and health outcomes, one thing we do know conclusively is that a pro-white bias, a pro-male bias, a pro-straight bias exists in healthcare among health professionals. That's been well established. And so the question then becomes, what do we do about it? And as I was listening to Dr. Brody share about the idea, the fact that racism is trauma. Racism is a pro-inflammatory, it can add to that pro-inflammatory state, it can add to that allostatic load. I think what I'd like to call attention to is understanding that this bias, racial bias, whether it's explicit or implicit, is trauma itself. And so if we can agree that trauma and racism encountered outside the hospital, in the community, in society, is a traumatic experience that can add to allostatic load, then why should racial bias encountered in the hospital, in the health system, be considered any differently? I think when we think about racism from a trauma perspective, there are some interesting associations that we need to recognize. The first one is that among people who have experienced substantial trauma, there is an association with this sort of inconsistent or erratic use of healthcare. For example, we know that people who've experienced substantial trauma have an increased likelihood of scheduling more primary care appointments, but then no show to them or cancel them at the last minute. There's also an association between trauma and utilization of the emergency department instead of having a regular primary care provider. There's an association with higher out-of-pocket medical costs. And then racism itself has been shown to be associated with delayed prenatal care. And so I think the important part about bias that we have to realize is that it's not just a driver of health disparities and some of these health outcomes that we pay attention to, but it actually can affect the way people who need health services engage in the health system. And if they engage in a manner that is not exactly aligned with what the health system would like them to do, or the way the health system is set up for that kind of patient engagement, it can lead to and promote difficult patient encounters, fractured relationships, miscommunication, misunderstanding, which can obviously influence clinical decision-making down the road.